Thank you so much for accepting our invitation.
The camera, is there somewhere where I should stand or where I should not stand? So, okay, good morning, everybody. Thank you very much, Rachel, for this very kind introduction. Thank you very much for the invitation. It's really a deep honor and a true pleasure to be here today. Thank you very much for this invitation. So this is the outline of the presentation. There will be only a very small glimpse of non-IBM myositis, just a few key facts of recent developments, or maybe the neurology perspective, if you may call it like that. And then we will hopefully have time to go into details on inclusion body myositis. You can see here my conflicts of interest. So as you all know, myositis really is a multi-organ disease, which means that, yes, the muscle is important, but it's not all. And we always have to bear that in mind in all diagnostic and treatment perspectives. So very important is that we all need to understand what we mean by a certain subset of myositis. Many times we see publications popping up with new words like scleromyositis, for example, or PM-METO, which is like a very modern expression of early quote-unquote IBM. However, it's important to stick to the established subsets of myositis, and we from International Myositis Society, we have published an editorial, and we think that currently we should stick with the juvenile myositis, other juvenile myositis, then dermatomyositis, clinically amyopathic dermatomyositis, polymyositis. We still think that this should be used. Inclusion body myositis, immune-mediated necrotizing myopathy, anti-synthetase syndrome, overlap syndrome, and also non-specific myositis. Why should we include also non-specific myositis? It has been part of previous classification criteria of myositis, because sometimes the pathological picture is not 100% clear and may not be consistent with the clinical and antibody picture. So we think it's important to adhere for that in order for patients to enter clinicals, in order to be accepted by the patients and the payers, and also, of course, to provide best care. We need to be specific with the subsets that we're using, and we are currently trying to mount a new ENMC workshop for next year to hopefully come to an international consensus. Regarding pathomechanisms in inflammatory myositis, we know that there are certain predisposing factors. Some of them are genetic factors, some of them are environmental factors, and the immune mechanisms, as you know, they center around B cells and autoantibody production, T cells, macrophages, and then very important is that within the skeletal muscle, we have a plethora of mechanisms in the field of cell stress, mitochondrial defects. We know that the protein turnover can be impaired, the proteasome and autophagic machinery, and all this can work together and then pose weak. All of you are very well aware that for precise, accurate diagnosis, we need to identify the myositis-specific autoantibodies. And I don't want to go into details. This is probably boring to you because you know all of it. But I would like to point out that this is not just for the classification, but also the magnitude of risk for certain cancers really depends on the autoantibody that you find. So it's not just like academic play, like which antibodies do we have and which we don't have, and is it myositis or is it not myositis? The antibodies that we find, particularly NXP2, TIF1 gamma, and HMGCR, they are highly associated with tumors. So if you have those antibodies, detail and see if an antibody, if the patient has a tumor. A new finding from last year I found intriguing. It was published in the Annals of Rheumatology Disease. And to my understanding, this is one of the best evidence we have so far that the antibodies, different ones, can really go into the muscle and pose harm and really act in the muscle and induce the muscle to change the expression of a whole range of certain transcription factors, inflammatory mediators, chemokines, and that a certain pattern of expression can then be dissected between the different antibodies. So from this publication, I think the final word is still out, but we do now have sufficient evidence that yes, these autoantibodies, they don't just happen to be there in the serum, they do seem to actually contribute to damage in the muscle and to changing the function and the biology in the muscle fibers. I would just like to highlight the muscle MRI. All of you know that this is a method of studying the function and the inflammation and the pattern of affection in the skeletal muscle. And it can help us to direct where to best do the biopsy for the patients. And if you want to understand publications, there was a good ENMC workshop published in Neuromuscular Disorders, and this is free to view. This summarizes all evidence in the area of MRI. Something that you may be a little bit less familiar with is the muscle ultrasound of the deep finger flexors. And this is now, and we will see it in a few minutes, this is now part of the diagnostic criteria for IBM. So this is really important, and not all neurologists do it, but many neurologists start to use it. What you can do is you can use the ultrasound to look at the deep finger flexors in the forearm, and only if you do you want me to continue or to pause? Okay. So, and only if you, patients may have a weakness of the finger flexors. And the difference is, for example, amyotrophic lateral sclerosis or neuropathies, they will have a different pattern of affection of the distal muscles. So there has been, thank you. Can I go back to presentation mode? Okay. So there has been this summary article, a meta-analysis of several published reports with 944 individual measurements. So we think that this is really a strong statement, and this is internationally accepted that we can use this technique. Okay, so in essence, we should, of course, look at the autoantibodies. We should look at the muscle MRI. We do not necessarily need contrast enhancement, so edema can be seen without contrast. EMG, does it play a role? Not necessarily for myositis, but rather to rule out other conditions for weakness, for example, neuropathies, ALS, or other conditions. Of course, muscle biopsy, although the current international criteria, ACI-EULA, would allow to make a diagnosis without the pathology, we think that still muscle pathology should still be a hallmark for diagnosis. So, and then when we do have identified the subsets, then we should search for tumors, and we should search for organ involvement. So when should we search for that? Particularly when we have certain autoantibodies present, like TIF1 gamma, or if patients have shortness of breath or other hints that they have problems with swallowing or with breathing. Regarding the muscle pathology, don't worry, I won't go into details. So this is all I will show regarding pathology of the different subsets. Every year we see a number of publications in this area with certain factors that are present in the one disease as opposed to the other. Particularly important is to dissect the myositis from other conditions like muscular dystrophy. And this can be really challenging, and I want to highlight this. This has been an ENMC workshop from 10 years ago with the top muscle pathologists in one room. And they had a Delphi assessment preceding the course with 24 cases that all experts were sure had myositis, different subsets. They had a consensus in 1 out of 24. So if your pathologist says, I'm sure this patient has subtype A, B, or C, he or she may be right, but she might not be right. So I think, yes, pathology is important. Yes, we need it, but still, we need to look at the full picture, and we should always have a mixture of the clinical workup, autoantibody testing, histological testing, before we make the diagnosis. It should never be the pathology alone. It should not be the antibody alone. And of course, it should not be only the clinical picture. And why is that? A few little highlights from the perspective of a neurologist. The CK in myositis may be normal, and this is published. The MRI may be normal. So if you have a patient and the CK is normal, you cannot say, no, you cannot have a muscular dystrophy, you cannot have a myositis. This is untrue. And if the MRI is normal, you cannot say, no, you don't have myositis. This is untrue. And this is why, and why is that? Because there are so many metabolic mechanisms that can lead to weakness, and we may not be able to pick it up by MRI. And we may have discrepancy between the different findings. Antibody may say disease A, pathology disease B. So we have to come together. We have to work together with the different disciplines. And this table of how to do it, sorry, it's too small to read from the back. It's taken from Melo et al. I think it's a Spanish group. Oh, it's from you, sorry. So I think it's an excellent summary of how to work together interdisciplinary. Okay, so this is all about a general myositis. And now we can move into details about inclusion body myositis. So inclusion body myositis, IBM, it presents with weakness of the quadriceps, weakness of the finger flexors. Many patients have dysphagia. In the muscle, you see inflammatory cells, you see degeneration, vacuoles, protein accumulation. And the important question is, what's the interrelationship between the inflammation and the degeneration? So the clinical pathologic considerations tell us that, yes, IBM has a very unique picture. The majority of the patients, they walk into your practice and you can tell that the patient has IBM. But again, just as much the pathologists can fail with the pathology diagnosis, we clinicians can fail too, because there are certain muscular dystrophies, myofibrillar myopathies, that really present with an identical weakness, with weakness of the finger flexors, with weakness of the quadriceps. And we have certain flags which come up in the diagnostic criteria that we need to adhere to, particularly when the patients are younger, particularly when there's a positive family history. And again, the pathology in myofibrillar myopathy, there can be inflammation and protein accumulation, and the same in muscular dystrophies. There can be protein accumulation and inflammation. So again, we need to have a puzzle of all of this together before we make the diagnosis. So now there will be a rather big part on the pathomechanisms of IBM, and I will look at you, and if all of you get too much puzzled, then I will maybe be a little bit quicker and maybe leave out the one or two studies. So since decades, so this is from '96, since decades, different groups in the world have tried to tackle this interrelationship or the pathomechanisms of degeneration and inflammation in IBM. It has clearly been shown that when you overexpress the precursor molecule of amyloid, APP, amyloid precursor protein, that there is degeneration and vacuoles in the muscle. And also if you overexpress directly beta amyloid, the muscle cells don't like it and they die. The same has been shown by various groups in mice. When you overexpress APP in the muscle, then the muscle shows vacuoles, protein accumulation, and the mice get weak. Different groups have used different proteins. Chris Weil's group used the TDP43, others APP alone or in conjunction with presenilin 1. This is like in the Alzheimer's world. What we do not see in all of these, in cell culture and in the mice, we do not see substantial inflammation. We see cell stress, but we do not see T cells. We do not see cellular infiltration. On the other hand, and to my understanding, this is not much used today, but I think it's an excellent paper published 25 years ago by the Plots group with the Nagaraju first author. They had an inducible tetracycline on-off model with local upregulation of MHC1 in the muscle. And what they could show is that when you overexpress MHC in the muscle, then you can induce inflammation. And then when you turn it off, the inflammation perpetuates, telling us that whatever harm you do to the muscle, there may be a point of no return, and there may be a self-chronicity in the muscle, which can be difficult to stop. We were among the first ones to show several years ago that when you overexpress cytokines for a long time in the cell culture system, you can induce accumulation of amyloid. And we could show in the muscles of IBM patients that there was a close proximity between accumulation of amyloid and inflammatory mediators. We then went on and could show that the vacuoles in IBM muscle was actually the place where the amyloid formed. And we could again use the previously established cell culture model with an overexpression of IL-1 beta and interferon gamma to induce this accumulation of amyloid through autophagic activity. Very early on, several years ago, in 2010 and 2006, the Italian group from Massimiliano Mirabella and colleagues proposed that there was a lack of regeneration in the muscle and that there was some kind of defect. And this has been taken up by several groups in the last years and very recently, and I would like to highlight a few of the recent findings. So a paper from 2 years ago from a German group, Christopher Nelke and others, and this was also shown during the last GCOM conference in Pittsburgh, showed that there is an adipocyte and fibroblast cell niche in IBM, which usually is required for an adequate turnover of the satellite cells. And this seems to be defective in patients with IBM. And they think that this is a reason for early senescence in IBM. Another very recently published article from De Vries et al. Was published in JCSM, Journal of Skeletal Muscle Cachexia and Sarcopenia, and they had a proteomics approach and could show in IBM that there was the mechanisms you would expect with upregulation of cell stress, inflammation compared to the controls, and that there was one factor, KDM5A, is a histone demethylase, which they found to be malfunctioning, and that this was connected with an impaired regenerative potential in the myofibers, particularly in the nuclei, and that when they had a inflammatory cell stress exposure with TNF-alpha, that they could mimic under this inflammation a downregulation of KDM5A. And as a proof of concept, when they blocked KDM5A with a pharmacological substance, they could block the regenerative capacity. So again, this is another way to possibly understand the mixture of degenerative and inflammatory pathways in the disease. And again, going back to the Morosetti group, they went on with their previous findings, and they already 13 years ago also had a similar finding with a different interlink between the regenerative capacity as evidenced by MyoD, which is an early protein in muscle development. And when they exposed muscle cells to tweak, this was a mechanism to reduce the MyoD presence. Very recent finding from last month published in Brain is that in the mouse system, when there is a profound overexpression of interferon gamma, this is sufficient to drive the muscle into atrophy and into enhanced degeneration. Of course, this is not inclusion body myositis, but it is a proof that inflammation alone can lead to reduction of regenerative capacity. And lastly, also a finding from this year in IBM cohort published highly in Nature Aging from a German group in collaboration with Tom Lloyd in the US, they looked at the different muscles in IBM and found that the different pattern and the different vulnerability of the muscle fibers differed in a way that there is a different susceptibility to the cell stress as opposed to, for example, certain fibers that have a different contraction potential. So usually the fiber types differ in type 1, type 2, and then type X and in between. So fast twitch and slow twitch, and that this composition of the muscle fibers posed a different vulnerability in IBM. Another evidence for the mitochondrial defect that we see in inclusion body myositis is known already since years, and there is a new publication that came out just this month in the September issue of Brain by a German group, Felix Kleefeld, who is now in Bochum, and they compared muscles from established IBM cases with the so-called Piamito cases. That means the histological picture of polymyositis with substantial increase of mitochondrial damage. And they suggest that the Piamito group is much more comparable to IBM. So they would think that this early defect of mitochondrial impairment is something that tells us that possibly this patient would lead into a two-cut IBM case later on. So they would think that Piamito is an early IBM. But I think the final word is still out on this. Some years back, we looked at the nitric oxide cell stress cascade, and we could show that in the fibers where we saw these fibers overexpressed inducible nitric oxide synthase, and that we could show NO stress as evidenced by nitrotyrosine staining. And in our established cell culture system with IL-1 beta and interferon gamma, we could see a tremendous several logs upregulation of INOS. And when we then looked at the cell culture staining, we could show nitrotyrosine, and we could also demonstrate it by flow cytometry. And if we blocked this with 1400 W, we could prevent cell death in these mice. So we went on, and this is in preparation. So these are unpublished observations so far. So we used the Kitazawa mouse, APP presenilin, double transgenic mice, and crossbred them with INOS deficiency. And we could show that in the 24 running wheel, sorry, I went backwards because this pointer was too fast. So we could see that the IBM mice were much less capable of running compared to the controls. And when we then crossbred with INOS deficiency, this could be corrected, and the mouse ran almost like the controls. And when we looked at the myopathology, we could see that over 24 months, there was less myopathologic defect and less amyloid present in the muscles. So we think that INOS is another molecule that could play a role between inflammation and degeneration. And a work which appeared just 2 weeks, so just in time for this talk, is a collaboration from the Göttingen group, Heidelberg, and Aachen. And we set out to induce a very strong inflammation in a mouse model with a transgenic overexpression of lymphotoxin. So lymphotoxin, as you know, is very important and is seen by lymphotoxin alpha and beta, by lymphotoxin receptors, and that this plays a role in a plethora of mechanisms for the proteasome and, of course, for upregulation of various chemokines and cytokines. So we started off with looking at the signature of inclusion body myositis compared to controls, and we could show that indeed in IBM compared to controls, we can see on the transcription level the typical signature of lymphotoxin induced changes with CXCL10, 13, CCL5, 19. And so this is what I just said. So we had a upregulation of lymphotoxin and then looked at the timeline for 6 and 9 months. And just by, of course, this is an artificial system, just by inducing this strong lymphotoxin, we saw mass infiltration of T cells, B cells, and a profound damage of the muscle, as you would expect. So we then went on and crossbred this lymphotoxin overexpressing mice with mice that were deficient for autophagy, so ATG5 deficiency. And now, in addition to the inflammation that was induced by lymphotoxin, we then saw the COX deficiency, the mitochondrial defect. We saw inclusions, we saw vacuoles, so the whole battery of degenerative changes. So we then tried different routes of treatment with prednisolone, with the depletion of T cells, and to make it short, none of these worked. What we could show is in our 24 automated running wheel detection system that, of course, as you would expect, these mice perform much weaker than the control mice. However, the treatments so far, all of the treatments that we used in this paper failed. So this is more or less reminiscent of what we see in inclusion body myositis, that the standard taking away the T cell, the standard reducing inflammation by prednisolone is not sufficient. However, so far we were unable to come up with an effective treatment. Our results are more or less nicely in line with a publication 3 years ago from the Tom Lloyd group with a xenograft model, where they showed that the accumulation with TDP in the muscles continued and could not be halted even when the T cells were depleted in their overexpressing system. So we think that collectively there is a suggestion that we have in IBM certain predisposing factors with an impaired regenerative capacity, with premature aging, with an impaired protein metabolism, and some impairment of cell stress counterregulation. So that an inflammatory stimulus can lead to degenerative features, accumulation of amyloid, TDP, 43, and this is interlinked by certain cell stress cascades like INOS heat shock, endoplasmic reticulum, and of course mitochondrial impairment. And then the end result of this mixture of different mechanisms is the fibrotic displacement and atrophy of the muscle fibers, and also fat replacement. So I would now go back to the clinical implications of inclusion body myositis, and I would like to show you the newest IBM classification, which was based on a workshop in 23, which was published in 2004. And this is an open access publication in a journal you would not necessarily usually read in, but all of these ENMC workshops are published in neuromuscular disorders. So starting off with the terminology, it was consensus of all of the experts that contributed to the workshop that we can drop sporadic from IBM because it would imply that there is a non-sporadic form, but we know all of those genes that have been established, MSP1, GNE, myofibrillar myopathy. So the consensus is that we should use inclusion body myositis full stop. And if we have familial IBM, or if we have genes affected, then we could call it by that gene. So the diagnostic criteria are as such that we start off with a common presentation, as we showed, with impairment of the finger flexors, impairment of the quadriceps. And now, for the first time, it's allowed that we have an uncommon presentation with only axial weakness, with only facial weakness, with only swallowing impairment. So this is quite an advancement. And of course, we need to make very sure that we are still dealing with IBM. So the consensus was that this should be in the hands of a neuromuscular expert who has seen such cases in order to make sure that this is not muscular dystrophy or maybe other condition that could mimic inclusion body myositis. So the second part would be that a biopsy is mandatory, and that the only mandatory feature is that we have to show inflammation, cellular inflammation. So if we have the typical picture with finger flexor impairment, quadriceps impairment, and we have inflammation, then we are done. And for those with the uncommon presentation, we need more evidence and could then still make the diagnosis, for example, if we have certain protein accumulation, or if we have the antibody present, or if we have imaging features, for example, the ultrasound of the long finger flexors, that they are positive. I think we started a little later. I hope we do have time. I think I should be within 45 minutes frame. Okay, thanks. So I would now go into details on dysphagia in IBM, which I think is a very important symptom. And I would like to remind all of us that swallowing is an active procedure. It's not just passively that we have water in the mouth and that it's the gravity pushing it down. We need, for this active motion, about 30 muscles. So we have certain phases, oral preparation, oral phase, pharyngeal phase, esophageal phase. And you don't need to test this now. Maybe you can ask your children. I asked my older daughter, and without any practice, she was able to drink upside down. So it's not just only, you don't have to be an artist from a fancy circus, any one of us. If you can swallow normally, you can swallow upside down. Well, I couldn't try this, but maybe some of you can. So this is the picture of the muscles that are involved. So it's not only the magnitude of muscles that are needed, it's also the sequential interaction of when one muscle starts and the other ends. So it's a difficult composition of action. And this can be disturbed by many disorders, particularly in the neurology field, so stroke, Parkinson's disease, ALS, myasthenia, but also some strictures or local barriers within the esophagus or pharynx can also lead to swallowing impairment, which we called dysphagia. It is an important symptom in IBM. About 2/3 of the patients have dysphagia. And dysphagia is an important symptom because it leads to impairment of quality of life, and it is a profound risk for aspiration and can lead to pneumonia or even death. On the contrary, although it is so important and although it is so common, it is many times neglected. So patients may not report that this is a symptom, and we as physicians may think, okay, it's aging or other factors, and we may fail to specifically ask the patients for swallowing impairments. When we want to look for the swallowing function, we all know very well that we have the FEES as a bedside test to look for the swallowing procedure. And the video fluoroscopy is a well-established technique. It's a radiographic technique to look for the swallowing in the pharynx. So a few years ago, we set out to test MRI swallowing. And this is pineapple juice, which is injected into the mouth through a syringe, and then the patient is asked to swallow. And what you can see here, I didn't want to overload the full talk with comparing different entities, but what hopefully you can appreciate is that there is a so-called pathophysiologic cricopharyngeal bar, exactly here, so that the esophagus, the transport in the esophagus, in the pharynx, lower pharynx, is slowed down and prevented, and that this is actually the reason for the swallowing impairment. So why do we need to do MRI, or why is this interesting? Because this is the only technique where we can look at the soft tissue and where we can precisely measure in this real-time MRI the different steps between the different phases of the swallowing, and which then allows us to do a quantitative analysis. And we did that and compared the different cohorts, and we compared the different techniques, and there is a very good correlation with the FEES and with the video fluoroscopy, and there is also an excellent correlation with the different swallowing scales. So right now, and I did not bring those preliminary data, we now have another manuscript under review comparing different diseases. So stay tuned, but one of these diseases is not a myositis, so I think it would be of less interest for you. But important is this cricopharyngeal bar, which I showed to you. And there's clear evidence from video fluoroscopic publications from Tyra et al. In 2020 that this is a risk factor for aspiration. So when we have patients with IBM, we should ask specifically if they have difficulty swallowing solid or liquid food, if they have to swallow multiple times, if they have to choke or cough during eating, if they have the impression that food gets stuck, if they avoid certain food, or if eating takes long time for them. So if this is the case, if we have IBM with dysphagia, then we should ask the patients to modify the diet, to have speech therapy. And there is one way of myotomy. So that's a one-time surgery. It's irreversible. It's very efficient. And another way to tackle the cricopharyngeal is by botulinum toxin injection. And there is a series, and this is a summary of all of the series with the publications with botulinum toxin in IBM patients. It's not 100% effective, but so far there have been no major complications. And the beauty is that it vanishes off. So even if you do it and the patient experiences side effects, it will wear off. And all of these studies suggest that it may be helpful for the patients. So final minutes regarding IVIG. This is a summary of all of the different IVIG reports, clinical studies, or case series in terms of swallowing in IBM. And there is a plethora of suggestion that IVIG or subcutaneous IG can help to improve the swallowing. And preliminary data from our group and a poster publication from 10 years ago showed that at least in a subset of IBM patients, immunoglobulin for a certain time can reduce the speed of progression. And we are currently putting together also these preliminary data from 68 cases. So clinical trials in IBM and case reports, they're all negative, and I don't know of many drugs that have not been tried in IBM. Recent failures were bimagrumab that was negative. That was a phase 2-3 study. Arimoclomol phase 2-3 study, big study cohorts, they were negative. Then there are ongoing trials, and there are two early phases. I won't go into details. There is the anti-KLRG1, and I will show one slide. Sirolimus, I will show one slide. And then there is a JAK1/2 inhibitor study, which takes place in France, actually. So why rapamycin, sirolimus? We had a phase 2 study led by Olivier Benveniste from France. The primary outcome measure was negative. However, the secondary outcome measures were positive. And in the community, it's believed that this is a positive trial. It is an international IIT, investigator-initiated trial, still going on in Australia, the US, and Europe. And we hope to be able to finally start later this year. There are the regulatory procedures that are still going on. Anti-KLRG1, that is an epitope in cytotoxic T cells, which have been shown a number of years ago by Steve Greenberg and others. And there is a clinical trial going on until end of this year, and we will expect the results to be shown during GCOM next year here in Lisbon. So we're all excited to hopefully hear good news from that. So to sum up, antibodies are important. We see a mixture of early senescence and impaired regeneration in IBM. Remind the new diagnostic criteria and the interdisciplinary workup. Please use MRI and ultrasound for the diagnostics. And it's possibly of interest for the future to consider real-time MRI for dysphagia as a research tool, and consider local injection of botulinum toxin for dysphagia in IBM. Here is a collection of important international networks. Of course, IMIOS is important. If you have interesting papers on myositis, I can suggest the home journal of IMIOS, Clinical Experimental Rheumatology. there will be high visibility because there will be one yearly issue on myositis. Your research will be seen. And of course, there will be, as Rachel already said, we will have the GCOM conference early next year. Thank you very much for your attention.
My question is related to the last part, actually, of the talk and the use of IVIG and IV. So we see that in clinical trials, we failed to efficacy, although we have the observational results and the experience that has been. So looking at the physiopathology that might explain the reason, separated from the other inflammatory myopathy, and also make a link, as we were discussing here, a little bit with Alzheimer, a little bit a connection in some aspects of the physiopathology. So how do you envision the possible role of IVIG in the context of this possible physiopathology?
Yeah.
Yeah.
So I do not think that IVIG is a very long-term effective treatment, but it may help at least a subset of patients to reduce some of the symptoms, at least over some time. And we think that, and we have proven this on a cell culture level, that by adding IVIG together under the inflammatory cell stress would reduce the degenerative component. So in other words, the accumulation of amyloid was reduced when we added IgG, human IgG, in the cell culture. So IgG, of course, can correct, as you know, many inflammatory cascades. So I think it can help to modulate inflammation, but I doubt that IVIG single treatment, even if we would have it for a long term, would be sufficient. In our hands, at least a third of the patients do respond. And in actually in two of the trials that have been done years back by Marinos Dolakas at NIH, the swallowing outcome measures were positive in that trial. And it's published. So, so I think particularly for patients with severe swallowing, it may be worth at least a try. Mm-hmm. The proteome modification, or what was the thrombotic, sorry, the thrombotic effect of Jo1. That's the only way of how I could answer this, because all of the basic science in mouse model or in cell culture, of course, in cell culture, you cannot study thrombotics, but from what I recall, all of the different antibodies have also given, have been given to mice. So Jo1, and I cannot recall having seen thrombotic events in these model systems. But I'm not sure. It may have been neglected during the reports, but I'm sorry, I cannot give a precise answer to that.
Surgery. But don't you consider, which one do you consider first? And would you consider also at the same time doing IVIG anyway before starting with the other procedures?
Yeah, so well, in Germany, luckily, we have the possibility to ask for IVIG. So it's, of course, it's an off-label procedure, but the German national guidelines would suggest that you may try IVIG in all IBM cases, at least for 6 months, and then see what happens. So yes, if we have patients, particularly with swallowing impairment, this would be our first approach to try IVIG. And then it's, of course, education of the patient, logopedia, and so on. And then normally we try botulinum toxin in all of the patients. And we would think that if a patient improves by botulinum toxin and then says, I do not want these repeat injections, then we would consider surgery. So this would be our approach. IVIG, then botulinum, and possibly surgery. Usually we try to avoid the surgery or talk to the patients.
Types of myositis.
Yes. Yes. So this is really only IBM. We have dysphagia, of course, severe dysphagia with requirement for feeding tube in many, as you know, myositis subsets. But luckily, the substantial treatment, when these are mostly the cases on ICU with high grade of paresis, that weakness of arms and legs, and then they also have swallowing impairment. Luckily, mostly they recover. So antisynthetase, so they have swallowing, breathing impairment, and severe weakness, and the aggressive treatment usually also helps the recovery of the swallowing impairment, at least to our experience.
And on behalf of our department to have you here, it was a really nice talk. Thank you for coming.
Thank you very much. Yeah.
For you, so take time to
Have the mics.
Oh.
Once I got out of the